Hello, everyone. This is Scott King with Becker's Healthcare. Thank you for joining us for today's webinar, What Healthcare Leaders Wish They'd Known Before Deploying AI in Patient Access. Before we begin, I'll walk us through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log in today's webinar to access the recording. If at any time you have issues with audio or visuals, just try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. With that, I'm pleased to introduce today's speakers. Sunny Eappen, MD, Chief Medical Officer, Assort Health. Matt Penrose, Director of Clinical Operations, TidalHealth Peninsula Orthopaedic Institute. Thank you, Dr. Eappen and Matt, for being here today. I'll now turn the floor over to Dr. Eappen to get us started.
Great. Thanks, Scott, and thank you for having us, Beckers, and thanks for everyone participating. Really appreciate it. So we're excited here to just talk about a very, very practical issue that I feel like I've seen at every healthcare institution I've been at, which is how do we get rid of obstacles in bringing our patients to the right provider at the right time? And so, Matt, I thought maybe we could just start with you telling us about the problem that you encountered, and then we can talk about how we work down to the solution. But just start with the problem for a start.
Yeah, thanks, Dr. Sunny, and thank you for everybody for joining. Yeah, I mean, our patient access had significant challenges. We were unable to fill schedules, mainly due to extended wait times. We had up to an hour and 45-minute wait times. We had a large abandonment rate. 40 to 45% of our calls were being dropped. Patients were frustrated. They would hang up, call back in. We had some patients who were literally driving because they were just so frustrated. They would drive to the clinics to make appointments. And then on top of that, we had a high attrition rate too. So we had a lot of turnover. So there were obvious challenges with all of our patient access at that time.
Yeah, and I think, you know, sometimes it's shocking when you actually say that out loud or when you imagine yourself in that type of a call hold. I mean, I've had that experience trying to change a flight or actually trying to get my own appointments. And there's sort of two perspectives I've seen. One is if you're in a competitive environment or you've got the opportunity to bring more patients in and you're not doing it, that's really frustrating, right? Because you're losing business. You're not allowing your patients to get in and get the care that they need. On the other side, you can have a situation where your access is really pretty challenging because you just don't have enough providers and you don't have enough staff, and you wind up having people do things that are outside of their caregiving piece in order to fill that gap. What side of that were you guys on before we go to the solution, or were you somewhere in the middle?
Yeah, I mean, I think the pain point was we had enough providers, so it wasn't really the provider piece of it, you know, and it was frustrating to hear the patient concerns because we have great providers who offer great care. And I think that, you know, the staffing, although we had high attrition, I think our staffing was adequately staffed for the number to take the calls. But I think our processes may not have been in place. And then we kept trying to hire more staff, and we knew we needed some sort of assistance beyond what we were currently doing.
Yeah, no, I think it's real. And it's just almost humanly impossible today for the folks that are answering the phones to manage the complexity that's coming in, and the fact that, you know, if you've got a number of locations and a number of different providers who all have their own, you know, specifications about what they want done before they get booked, or that their appointment times may be different. All of those things can play a factor. Give us a little bit more about how your office and your setup was at that time.
Yeah, I think like most orthopedic offices out there, we have subspecialties, and each one of those providers have specific nuances, decision trees that they want followed, whether it be just the chief complaint that they're seeing or age restrictions, whatever it may be. And it's exceptionally challenging for staff members to remember all of those decision trees. And one of the things I'll probably touch on a little bit later is that when we went live with Assort and AI, that it's really more accurate testing and more accurate scheduling because you can program the algorithm in there and it doesn't get it wrong. So once you go through and get everything set up the way that you want it.
And did you have a couple of people that had an enormous amount of history, or was it just you were going through people and so no one really had the history of all of those practitioners or the locations?
Well, we had a few long-standing staff members, but our attrition rate was significant. So there wasn't a lot of history there. You know, we had cheat sheets that were written down, and in the EMR that we had at the time, the HR we had at the time, we had some steps in there to assist, but it wasn't providing enough information to go through there. And staff would definitely stray a little bit. You know, you'd have a hand on a foot and ankle surgeon, and the providers would get frustrated. And it's tough. You know, at that time, we had 40 to 45 providers. We had 6 clinic locations. We've grown a little bit since then. But it was tough for everybody to remember. And, you know, we also have a dedicated call center, and, you know, they're in their own little location on site, but at the same time, they're not interacting every day with those providers. You know, we have locations in 2 states, Maryland and Delaware, and they don't even know some of the providers at all. So they don't have that relationship to have the nuances that the providers need.
Sure. And what was tougher than you thought when you went from sort of that manual to the agentic voice? What was the harder than you expected, or what was hard in that translation for your staff?
For the staff themselves?
For the staff or for the office as a whole?
Yeah, I think overall the transition was way better than anybody anticipated, quite honestly. You know, there were challenges when we did it. Some of the providers were frustrated. You'd have a patient who would say, oh, they didn't even know you were a provider here. And some of the things we discovered early on was that each patient may say a provider's name a little bit differently. So if we have a Dr. Trager and they say Traeger or Trotter, or Dr. Vader even got thrown out there, you know. And we didn't have the AI programmed at that time to recognize those nuances. And since then, we've corrected that, and that's not an issue anymore. The other thing was we have 2 providers whose first name is Scott and one whose last name is Scott, and couldn't recognize the differences between that. So that created some early on frustrations for patients, providers, staff, because they're getting the complaints, you know. But we've since worked through all of that.
Yeah, and I think you guys were very early in this process. I think today we take those similar names and actually program them in and practice them beforehand, so that sometimes you have actually the practice could have 2 providers with the same last name, identical, yeah, right? And not just the first name. And you have to actually differentiate that out, almost in the same way that you have to differentiate patients out. You know, you have to ask them for their birth date and spell their name and things like that. But yes, I think we've gotten smarter. That's a great example of the evolution, right? Evolution of the product, but also the steps that you have to take before you start, and that you have to evolve as you're going along. So I love that. That's a great example. When you were making the decision about using the technology, now it sounded like you guys were struggling with getting the patients in, and people were waiting a long time. So I could see the need, but what were the concerns that you had and that your providers had at the time?
Yeah, so I mean, yeah, we're going back over 1.5 years, and in October it'll be 2 years. So at that time, AI was just getting started. So, you know, a lot of people didn't trust AI. We didn't know what the capabilities were, and you know, we're in a fairly rural area as well. We're not metropolitan. And although, you know, we have people who are very tech savvy, in general population has concerns about that. So we were worried about the providers not being able to pick up provider nuances. We were worried about patient concerns over it. Staff losing their jobs, you know, was a concern that came up. And we worked through all of those different things. But I think that overall, it was the decision was that we had a struggle where we did our homework with it. Could the technology do the job? Nobody, none of us really knew that at that point. And then, what's the integration process look like with our EHR, with the other systems we had in place? At the end of the day, we got rid of several other applications that we had in place. So Assort helped us replace those. So from a cost standing, that was a savings for us. From a standpoint of losing staff, I had the conversation with them, and it was really, this is here to support you. And quite honestly, that was the case. So staff were obviously concerned. We already had high attrition rate anyway. Our attrition rate dropped off significantly from the time we implemented it, and to where the staff truly did feel supported by the technology. Their call volumes went down, and they were handling more complicated calls. And I think that overall we were in a much better place because of it. So.
Yeah, and it's interesting because the questions do change, right? After you put it into place. Just remind us what is the EMR that you're on?
Yeah, so we're currently on Epic. At the time, we had Athena. We switched over about a year and a half ago to Epic, and we didn't have any major complications with Assort connecting to either of those EHRs.
So Assort switched from, you started with Assort and Athena, and then you switched over to Epic, and you were able to manage all of that. You guys were, yeah.
Yeah, we were actually, to my knowledge, the first group with Assort to go live in Epic. So we worked through the APIs and those pieces, and everything worked pretty seamlessly. We were able to put all the existing decision trees that we had in place with provider scheduling that we had, whether it was on paper or whatever we had, right? Put those into Epic. Assort copied those over really well. And then we also have those implemented in MyChart scheduling. So through the Epic patient access portal.
I'm sorry, Matt. Did you have to actually change any of your workflows? Did you make people change anything, or were you able to keep what people were doing and just the system adapted?
Yeah, we just kept enhancing the workflows. One of the nice things that we had with Assort that we never had before was a warm handoff. So any of the, if a patient calls in, they have the conversation with Assort, right, with our agent, and for whatever reasons that we put in place where it has to transfer over to a live agent, there's a warm handoff piece there where the live agent can just quickly read over the notes without having the patient to repeat everything. So that was a nice adaptation that Assort was able to implement for us. And, it's a time savings as well as a patient satisfier that they don't have to keep repeating things. Right?
Yeah. Yeah. And it sounds like you took the complex issues or complex insurance issues, and those went to your office staff. So the voice agent just sort of passed those on. Was there anything else that was surprising to you? Were there any sort of crazy things that we worry about in the hallucination space, or how did you have, what else unexpected occurred, or maybe it didn't?
Yeah, some of the unexpected positive things. I thought we were pretty strong on our metrics, but discovered that over 40% of our calls are patient confirmation. And that even though we send 3 text message reminders to every patient, there's 40% of that population is still calling in saying, hey, I want to verify I still have my appointment. So the nice thing is Assort took all those simple calls off of the plates, and our live agents were able to handle those more challenging calls. We have our decision tree set up, or the algorithm for Assort. So if it's a VA, a workers' comp, certain insurances, the managed care stuff, and then PIP auto that they kick over to a live agent. Or if at any point a patient decides that they want to talk to a live agent, all they need to say is live agent, and it kicks right over. So
yeah, so that's
the
great.
Other nice pieces, I'm sorry.
Yeah, these metrics are pretty spectacular. I mean, the change, the idea that you went from a 90-minute wait time to literally seconds? Is that literally seconds that the
Oh,
switch
yeah,
is?
literally. So most days we're around a 30-second wait time. And the thing to keep in mind is there's no wait time for Assort's agent. They take the phone instantly. They take 1,000 calls, whatever you need to do, all at the same time. That wait time is for our live agents. So now we went from 9 patient access reps down to 5, and they're more efficient than they ever were, and they're happier because they got less call volume. We were getting 2,200 to 2,500 calls a day. And that is cut almost in half because of the patient frustration. I didn't recognize how many patients were hanging up, calling back in, trying to get back in line in a better time frame, right? And so our overall call volume dropped, the wait times, the abandonment rate, we're averaging 6 to 7%. Some days we're at 2 to 4% abandonment rate. People aren't frustrated. They're not hanging up. And we're filling our provider schedules, which at the end of the day is what we want to do. So
yeah,
one of the other things that we did, I'm sorry to dig too much in these metrics, but they're pretty exciting, right? But the other thing is that our cancellation rate cut in half as well. So patients calling in to cancel appointments, we switched it over, as simple as it sounds, but we switched it to where we have the Assort agent say, instead of canceling, is there a time that better suits you that we can help you reschedule? And patients are like, yeah. So before, they'd call into live agent, hey, I want to cancel. Okay, they cancel and we move on, right? In this case, the cancellation rate's cut in half. So that's another significant advancement.
Amazing. Was there anything in that hallucination space, any incidental or anecdotal stories? Nothing. You didn't?
No, nothing crazy happened like that. And, and we did audits, we did our due diligence, and we still do audits to this day, but, we don't audit it every single call like we did during the implementation phase. But no, and, it's no hallucinations, none of that stuff.
Yeah, it's great to hear. I mean, I think that's when I talk about it with docs, with provider practices, it's one of the fears they have is this hallucination thing and that we're going to miss something that's important. So that's great to hear that didn't happen. And did you find the trust in the system grew as time went on? And did that change anything? Did you do something different as a result of that? Or just people felt better, you didn't have to audit every single call?
Yeah, it was trusted. So we cut it down to, we do a daily audit of 10 calls is all we do now. But it built up over time. We went from during the implementation, we started on day one, we had a single call that we did, right? And then we built it up. So, but it's accurate. Quite honestly, the AI agent schedules more accurately than our live agents. So.
Yeah. And did you notice that thing? I was going to say, did you notice that things got better over time? And clearly, it's interesting to me that the after hours calls went way up. Is there a story there, or what do you make of that?
Well, we didn't have any after hours process for scheduling. We had an on-call for providers, right? But we didn't have anything in place there. And that was one of the things that once we gained trust in the system, which quite honestly didn't take long, but once we gained trust, it's all right, let's open this thing up 24/7. And some of the great pieces of that are that, there's people who work all different hours, right? And they want to schedule at different times. The other nice thing is not that we have much bad weather in Maryland where we live, but we did have a few days this past year and where we had to cancel the office, and patients were able to call in and reschedule when our business was closed. So on those days, we had a high volume calling in, and they were able to reschedule and go about their day. They were home anyway because they were snowed out from wherever they were working, most likely. And so it's nice to have that 24/7 just availability to schedule and fit your lifestyle if that's something you choose to do.
Yeah, no, that's one of the biggest obstacles, right? Particularly if you have a small office with a small staff, oftentimes they'll even close down during lunch. They won't answer calls. I had that experience where, between 12 and 1 or 11:30 and 12:30, which is of course the time when our patients are off and they can call, right? I mean, that's the irony of it. and certainly after hours really does make a difference. Did you employ the outgoing feature? So let's say a doc or a provider was ill and you had to cancel patients. Was Assort calling outbound as well, or not?
We have not implemented that. We have a campaign like that we can do a text message campaign through the MyChart application through Epic. We had considered doing that, and I see the benefit of it because it keeps our live agents from making that call to reschedule. We just haven't made that step yet.
Got it. Anything else that's changed internally? Have you learned anything since you've implemented the system over the last year?
I feel like we keep learning all the time.
Other bottlenecks, for example, that pop up. Once you get rid of one, another bottleneck pops up. I don't know if you guys have experienced that at all.
Not so much on the patient access side of things. I think that that there's other things that I want us to be able to implement on, which I think it's technology that Assort's working on now with fax queues and things like that. But we haven't really found other bottlenecks beyond that with the patient access piece. This is a kiss of death, right? But we're in a really good spot with patient access, and
that's great.
And it's our staff are happy, the patients are happy. We're right where we need to be. There's always room for improvement, certainly, and I think we keep making those tweaks. Some of the things that we keep working on is how to ask the question differently so patients answer it in a way to get them off the phone a little bit quicker. So, and we've made progress on that. We've got our call times down with the Assort agent down probably about 2.5 minutes from our original call times, and we keep trying to tweak that, right? So whether it's through an audit or a customer concern about something, we've got the ability to listen to every call. So if there's a customer concern, you just listen to the call. It's like, okay, how can we make this better? And if one person has an issue with it, most likely other people do. So I think there's always room for improvement, no matter how good you feel you're in the space.
Yeah.
And those are some of the tweaks that we do, is just try to get that call time down a little bit. So
sure.
But certainly,
did you change anything? I'm sorry, Matt. Say that again.
I was going to say that call time is still better than a long wait time. Right?
Sure, absolutely. No, as long as the patient is engaged, it feels like opportunity, right? Is there anything that you changed that the staff handle? Like, were you able to move some of those exceptions? I just don't know the answer, but over to the Assort agent, or did you pretty much set up your system up front and then that actually has worked quite well?
Our staff have more time to achieve tasks that they weren't getting to before. So like some of the work queues that are in Epic, we're always lagging behind. And our staff have time. So we were able to move some of the tasks off of one group. So like our medical information team had some things that really didn't fit their work, their job description, so to speak. And we're able to move those over to our patient access team just because they had more availability to do it. And from a general workflow, I think that's helped quite a bit.
Yeah. And for your providers, other than getting the patients in the door and them not hearing the complaints when they came in about how hard it was to schedule, did they have to change anything in their workflows? Was there anything that you changed, or did they just continue to do the work, seeing their patients?
Yeah, they just kept rolling on. We had those initial concerns about the wrong name, right? And certainly due to the we'll call it temperaments of some surgeons, that they want their name pronounced correctly, right? And then they want, but as long as they have a full schedule and patients have access, and it was better than it was before, which is the case, they're happy. They're rolling right along, and we put all of the decision tree criteria into Assort that they had already, and as I said earlier, Assort's scheduling it more accurately than our live agents. So,
yeah, one of the things that I'd heard of was when Assort the AI agent starts working well and you're moving all these patients that are calling in, that the roadblock people noticed were that referrals coming through? And how do you get referrals today? Are they coming via fax? Are they coming electronically? How do you manage those? And is there a role here, again, for an agent to help you in that space? Or have you noticed a difference?
Yeah. So currently we have a mix of referral intake. So what we have, so one of the work queues I was talking about is a incoming work referral to be scheduled work queue. So we have time to navigate that through Epic better than we did before. We also get them through faxes, and then we have a separate doctor's line that referrals come in through. And I think that the opportunity there is for Assort to be able to go in, pull that work queue out of Epic, call the patient without a live person handling it and fitting it through the decision tree into the existing schedules in Epic that we already have, and just popping them in there. And I know there's some work being done on that right now. We're not live with that yet. We're working towards getting to that point. That's our goal. And I think that not only through those work queues, the other thing that I believe Assort went live with on Athena, but not Epic yet. You can correct me if I'm wrong, but is pulling out of the fax queue, referrals out of the fax queue and calling for them. Our fax queue remains to be a challenge for us. We're getting 350 faxes a day. And if we skip 2 days, now we're pushing 1,000 faxes on there that are in there for various reasons. I think that there's great opportunity there. I'd like to work with Assort to get us to where we're not going through the fax queue with a live agent, because nobody wants to sit there and go through faxes all day, right? And quite honestly, with 350 faxes coming in a day, that's what we have to do. So
I do think that the technology is moving so fast. I can tell you, maybe offline, I'll connect you to the right people on here, but the ability to read faxes and process them is here now. And so the opportunity is live. And I think putting that into place sounds like this is a huge issue. It's crazy how busy you guys are, 350 faxes a day coming in to your practice. I mean, I want to summarize and keep us moving and get to the questions that may be there. But overall, as you think about, give us a little bit of a perspective over the last, you said 12 to 18 months when you guys have had this in place. How has your staffing changed, both in the provider side and in the call center management side? Have you grown in this time? What have you had to do with your call center folks, people managing the calls while you've had this in place? Give us an idea of the last 18 months.
Yeah. So, we were Peninsula Orthopaedic Associates up until July of this year. And then we entered into an MSA with our local healthcare system, TidalHealth. As a result of that, we took on 2 more clinic locations. We took on 11 more providers. And we haven't changed anything to this point. We're continuing to work through that implementation piece, where we're just a month and a half deep with our growth potential. But we've got last year we added 3 surgeons through the POA side of things, and just kept plugging right along like nothing happened. We've got 3 more starting next month, actually, and then 2 more committed for next year. And as a result of that, I was looking at the numbers. Do we need to add more patient access? And at this point, I don't think we do. So I think that there's opportunity there. I think, certainly if we get this fax referral in check the way that I'm hoping it does. And so, we went as I said, from 9 down to 5, and the attrition's not happening. So the staff are not working the overtime. They're not frustrated. So I think we're still in a good place, even though we're taking on additional volume.
Yeah. So what it sounds like, just to summarize that, it sounds like you've continued to grow pretty significantly with adding more providers, but the number of access folks has actually dropped, and it has stayed constant, and your turnover rates dropped, or or been non-existent. So that's actually a great story in and of itself, Matt. That's a credit to your team and the technology that's in place there. So just to summarize overall, if you had to think about, when you look back, anything you would do differently, anything we can learn from, as lots of systems are a little bit hesitant to jump to AI maybe. What can you tell them to help guide the rest of the folks that are here on the screen?
Yeah, I mean, I'm not sure there's anything I would have done differently. I told this story to some people before, but it was new. That we talked before about the concerns that were out there, and we were in a bad place. And quite honestly, I went home one day and I said to my wife, "Hey, I'm going to go live earlier than expected with the AI." And she said, "What's that mean?" I said, "That means I'm either going to be a hero or I'm getting fired tomorrow." And I'm still here almost 2 years later. So
sounds like you're a hero there, honestly, which is amazing. That's great. Anything that you would, it feels like you guys were bold in jumping in. Was there anxiety or trepidation with your overall team, or were you guys just an optimistic group overall?
I'd say overall, not everybody is as bold as I may be to jump in on some things. But, we did our due diligence. We had what I thought was accurate metrics, besides the surprising piece on the confirmation of number of calls. But now I felt like we had metrics in place. I felt like we knew what our challenges were. We knew that we had to do something different, that there was an opportunity here to do something that nobody else was doing, and take a leap of faith on it, and if we'd gone through the implementation phase and it was failing, we wouldn't have pulled the trigger, right? So, we took those steps, and we took, things that made sense to fix the problems that we had, and we wouldn't have done it otherwise if it wasn't working through those initial steps of implementation. And I think that if you decide to do this, work with a team, like Assort, it's going to help you figure out exactly what you need, fit that algorithm to your needs, not somebody else's needs. And then as you continue to come across what may be challenges, work with the team to figure out another way to solve it, right? So.
Did the cost estimates pan out? Did you wind up spending more or less than what you expected?
Overall, less, because of the value of it. So whether it's tangible value like staffing or canceled appointments, things like that, or if it's just customer satisfaction, it was well worth the cost of it. As I said earlier, we've got some great surgeons and great staff here, and I'm proud of our team and the work they do every day, right? But we're hearing those negative complaints, and it just kept getting worse and worse. And in a rural community like ours, those negative concerns travel quickly, and we had to do something to stop it, and we were able to do that.
That's great. And did you feel like you needed technology expertise on your end, or was that all handled on the vendor end of this? Like, did you guys have some expertise? Like, how much of a pull on your system or people was it during that implementation and maintenance?
It was a group effort. I think one of the reasons why we were able to take the chance to implement AI early on was because our CEO is very tech savvy. So he's very knowledgeable. Our IT team had some involvement in it, but it was Assort guiding the way, and we had some clinical application specialists on our end to assist as well. And like anything else, it's successful. It's always a team effort. It's not just one person dictating how things go. Yeah.
That's great. So I guess I want to open up for questions just to close up here. This is what we wish we had known kind of thing to end, Matt. We have a quote from each of us. Anything you want to build on that or say?
No, I think I said it before, but just, if you've got a problem, the risk, I think, is not doing anything, right? So you know the problem's there. Get your metrics in order. Verify that the problem is not a particular staff member or something like that, right? That's causing the problem. And verify that the problem's real. Your metrics are going to prove that. Work through it. Talk to your staff about it, and then reach out to, whether it's Assort or somebody else, but, reach out and then find out if that's the right partner that you want moving forward. And are they going to be able to adapt and grow as you adapt and grow? And I think if that's the case, you're going to have a good partnership.
Yeah, no, that's great. And I was always living in this space of, AI is out there and there's a solution, but we're not sure what our problem is on the inside. And my fear in that role when we were looking at different vendors coming in was that how much work would we need to do as an organization to streamline our processes within our providers and our offices. And what has become apparent is that with the technology moving forward as it is, we don't have to create uniform practices or uniform surgical practices or uniformity even within a subdivision now, because these products are so bespoke that they can solve the unique situations in our practices across locations. And for me, it's been a real lesson to see that change, because I felt like in the past with our EMRs, we had to really unify before we could go to doing these sort of smart pieces and allowing patients to schedule on their own. Today, we don't need to do that anymore. AI has sort of catapulted us over that. So it's been great. Scott, I'm going to hand it back to you to see if we've got any questions for either Matt or me or both of us.
Absolutely. And thank you, Dr. Eappen and Matt, for a wonderful discussion today. We'll now begin today's Q&A. And audience, please feel free to submit your questions via the Q&A box on your screen. Let's go ahead and get started with the first question. How long did it take from design to implementation phases?
I guess that's for me. So I guess we were scheduled for 3 months, but as I said, I pulled the trigger a little bit earlier because as we went through those steps, we started literally getting the decision tree put in place, the providers in place. We had everything in place, and then we did one call one day, and then we scrutinized the call, right? And it wasn't a perfect call by any stretch of the imagination. And keep in mind, this is going back 18, 20 months at this point, right? And then the next day we did 5 calls. And then, the plan was to keep growing that up. Once we got to 50 calls, we were supposed to go up to 200 calls. Once we got to 50, we had fine-tuned things so much that it was already significantly better. So, and we were watching real time. So when we would turn it on during that phase of getting those 50 calls, our call volume and our wait times, all those metrics, you could see them change live to what we wanted them to be. And then that's when I went home, and the story I shared with my wife that I may be getting fired the next day, right? I said, I'm going early. So, we ended up going, I would say 3 weeks early, I think is what we ended up doing, just because it was already showing benefits. And, the negative part of that, which isn't negative, but one of the small hiccups now that I'm thinking back of it, is that we were going live. And then I had our metric screen up, our call center all day long for the first 3 months of this. I was just constantly, our patients access supervisor and I were just monitoring everything, right? And all of a sudden our wait times went up and our call volume shot out. I was like, God, what is going on? So I contacted Assort real quick, and I was like, and they're like, all right, we found a hiccup. We're working on it. And 5 minutes later, it was resolved. But that's how beneficial having that live, the AI agent helping our live team. Like, you just see the impact of it instantly. It's phenomenal, really.
It really is a flipping of a switch, right? And I think that as we look at the implementations now, there have been over 250, 260 implementations with 25 different specialty groups. the experience level of the implementation team just continues to grow. And I think what we've seen is, we think we have a best practice for you pick your specialty of how to roll it out. And then there's always a little bit of customization on the other side that sometimes can slow things down a little bit. But if anything, I think your story is very, very much in the norm today. Of course, there's complexity based on the number of providers you're bringing on at once and the number of locations. So that can stretch that timeline a little bit. But I think what you're describing is well within sort of the norm, Matt. And so that's great. Scott, I'm going to send it back to you.
Sure. Moving on to the next question. What metrics indicate an AI deployment is genuinely improving access rather than just reducing labor or increasing containment?
Yeah, I would say, what we focus on is the abandonment rate. How many patients are hanging up because they're frustrated, and are they calling the provider in the next county over, right, or the next block, whatever it may be. And then the number of calls, the wait times, number of calls our agents are taking, and then the abandonment rate are the three main metrics that we're taking on.
Yeah, I mean, at the end of the day, it's really about how many patients are getting booked, how many patients are the agents taking from the call all the way through scheduling, and those metrics are there, so you're able to see them. That's the load that's being taken off of any of the call center agents, and decreasing the need for those folks to be doing those simple things. I think one of the startling things that you brought up, Matt, that I remember is that 40% number where people are just calling to confirm, right? Just taking the time to do that, to make sure. And just to eliminate that is a huge load. So got it. Next question.
How are you measuring the patient satisfaction? Is it qualitative or NPS score?
So we initially, during implementation, we sent out our own patient surveys, and they're still matching to this time. So the surveys we sent out were just basic, like, was it a positive experience with the AI or not, right? And we were around 4.5 out of 5 that were positive. And we had already known that we were negative, getting negative feedback without the AI agent. So we kept going forward with it. And then to this day, Assort tracks that. Assort's got a really nice dashboard with the metrics on there for what they're tracking. And it'll show you the number of calls coming in, new patient versus established patient, urgent care, how many each provider gets, chief complaint, so by body part. It's broken down really nicely. I hope that answers the question.
Yeah, I think Assort in the implementation and the ongoing use at the very base just asks a very simple question. At the end, it just says rate it 1 to 5, 5 being it was a great call, handled everything, 1 being really poor, and just add any comments that you want. And so it'll just take that. You can choose to do it or not, but that's the question that gets asked. If a particular provider wants more detail, they can actually get that. You guys took the extra step of sending out your independent survey, so it was unbiased in any way. So I think that's great. Scott, next question. I love it. I love these questions coming in.
What cues the AI to hand off the call to staff?
Yes, so we set our own criteria for that, and I'm sure anybody can set whatever they wanted to do, right? So there's a number of things. So if it's a workers' comp, if it's an auto accident, if it is if the patient at any time says agent, live agent, person, anything like that, it kicks over. If the AI agent has to ask the question more than 3 times, I think, and that the patient doesn't answer it, or perhaps there's a misunderstanding of some kind, it kicks over to a live agent. Or if there's just silence for, I want to say we have it set at 20 seconds. I'd have to revisit what that actually is. But but those kick over as well as some insurance types kick over. So when we get to the insurance question, it'll kick over.
Yeah. Those are just so, adaptable, malleable to the practice. But then there's also, I think it's really important that the safety piece is also there. If a patient brings up something that triggers that there's a sense of urgency or emergency that needs to be handled, again, there's sort of we have a package on the best practice side, but then each practice can add their own piece of what they think needs to be triggered to talk to a live agent. That similarly happens after hours. If there's something that, it's not just simply booking or rebooking or recanceling and rescheduling, but there's something urgent going on that does get transferred over. The agents are pretty good. I think they're today programmed to be hypersensitive, I would say, about making sure we don't miss something that's safety related. So I think that happens really quickly. What's next?
What needed to be in place from a leadership and change management perspective to ensure successful execution across both people and technology?
Yeah, I think that, being in touch with your staff members and having direct conversations with them about what this change, what we think it's going to look like. And then as we're going through those changes, having conversations with the staff, and then, showing them the metrics and showing them that, hey, like, this is a benefit to you, right? That the hold times are not there and you're not having patients frustrated because they've been on hold for an hour and a half or whatever it may be. And that the general level of the calls were less frustrating. And I think that was a big piece with maintaining our attrition, or not maintaining attrition, but lack of attrition. I think that the patients weren't as frustrated, so therefore our staff members weren't hearing negative comments, or as many negative comments, I guess I should say. As far as the other changes, it's workflow and, all right, we solved this problem, what's next type thing, right?
Scott, next.
So is everyone happy with AI?
Everyone? No. There are some patients who are going to call in and not like AI no matter what, and we have a process for that. They can kick right over to a live agent. What we announce up front that, hey, I'm a virtual assistant here to help you. So we're not trying to surprise anybody, no matter how real the conversation sounds. And there are people who, as you screen calls or listen to a call, there are people who, even though we say it, I don't think they know they're talking to an AI agent, because they're saying, okay, thank you, hope you have a good day. And, at the end of the call, and one of the other things we didn't touch on either is that there's also the option for somebody to receive the form via text. All right. So if they don't want to, so when they call in to schedule and they don't want to talk to an AI agent, we ask, do you want to receive this form via text? And then they can fill out everything they need to on their cell phone if they want, instead of working through the AI agent. So there's options out there, whether it's a live agent, a form, or the AI. Yeah.
Matt, how did you prepare your patients? Like when you knew that you guys were moving, what did you do to get the patients ready?
Yeah, we had signage everywhere. So on our TV screens in all of our lobbies, we put, hey, coming in 3 months, here's where we are, the back of every door, and then some conversations with patients as they're asking about the signage or whatever it may be. But, I had to have my staff knowledgeable enough, whether, not just patient access, but our MAs and patient services at the front desk. Everybody had to have some knowledge of, hey, this is coming and this is what we hope it means, right? So it's not just throw it out there and here we go, so.
Got it. Scott?
How do you handle warm handoff after hours? Do you have staff support? If outbound calling is offered during business calls, then how do you prioritize the queue?
Yeah, so we do not have anybody off hours. The only thing we did change, instead of coming in at 8 o'clock, all of our patient access reps in the call center, we have one person come in at 7:30. and they review any call that was made after hours to ensure that it's accurate. And what we did, we built in place that the after hours call cannot be scheduled within the first 2 hours of clinic hours. So that enables our staff to go through, verify that, number one, we take the insurance. Number two, it's scheduled with the right patient or the right provider for the chief complaint. So we put a process in place to handle that. That seems to be working well. I've not heard of any concerns around that. And then even throughout the day, we have in place that just to ensure you can't schedule within 2 hours of an appointment time is how we have it set. So if it calls in, if it's within 2 hours of an appointment time, that does kick over to a live agent, just to ensure that it's being handled appropriately.
I would say, Matt, on all of those factors today, quite frankly, like we're almost beyond all of that, meaning that it's so accurate. It's partly trust, it's partly internal systems on getting that, but it's pretty good. It's pretty good. It's gotten better and better in that space. So and the prior auth piece is a whole other issue, right? Because there's so many different variants of even whatever one insurance product, and that's gotten pretty sophisticated so that can be checked and confirmed today. So I think you need to have a conversation with your representative to move those even and get better. But the technology, it is really moving and moving quickly. Scott?
Dr. Eappen, how did you build trust with the patient, and how do you handle accessibility, inclusivity, in parentheses, multilingual support bias?
Yeah, so I think, again, the technology has gotten so good, both in the voice and the language. So I'll just bring up a couple of things. On the voice side, the idea of the specialization in the linguistic part of it, of the tone, the volume, the understanding and capacity to understand how different languages work and how you have to speak, has just gotten really good. Latency, that is like how long do you wait before you jump in? So there's a little art there, right? Because you don't want to interrupt. I have a problem with that. You don't want to interrupt. You want to wait long enough that you're not interrupting, but you also don't want dead time while you're waiting. All of those factors have just gotten so much better today. Not perfect, but they've gotten better, and that is going to keep getting better. That's one. The idea that the agent can remember, the Assort agent can remember you after one call. So it remembers that you prefer Spanish, that you're a little hard of hearing, so it needs to speak louder because you asked to. The next time it calls you, it will remember those things. That builds a lot of trust compared to, every time you call, you've got to go through that rigmarole each time of getting the language right. So I think all of those factors that are coming in and more as it gets more and more sophisticated help to build the trust for our patients to have those conversations. And I think what Matt said is it's real. That is that patients forget that they're speaking to an agent as it gets better and better. They're just talking to someone that's helping them, a trusted member of the team, which is the goal. This is a trusted member of your team.
And our final question, what's the next application of AI that you're looking at or evaluating?
Yeah, it's definitely two things. So faxes, trying to get those referrals out of the fax queue, the ability to go through, do document sorting through the fax queue, and then put, if it needs to go in a patient chart, go ahead and put it right into the patient chart. If it needs to go to or if it's a referral, go ahead and call and make that appointment. The other piece is the work queues for the ability to go through the referral work queues and schedule right out of there. So those are two things that are hot on our plates and that we want to work towards to get implemented.
Yeah, I would just, maybe I'll add one minute on that and just say those are hot, right? How do we take a referral that's come in, whether electronic or through fax, and convert that, make sure you pull all the information, document it, and then convert that right into an appointment without a human there. That's big. prior authorization. So the complexity there of sometimes rapidly changing rules and how do we convert that into calls. And then third, I would say, is on the outgoing side, particularly in population health related areas where you need to close care gaps, whether that's colon cancer screening, mammography, hemoglobin A1C checks. All of those are up and live and real. And I think those are big pieces that health systems in particular are very eager to move forward on. So I think those three things, I just add that last one to what Matt said. So thank you. Thank you all for participating. Thank you for the questions. You can see the barcodes on the screen if you are interested in talking to either one of us or getting more information. I think we've made ourselves available for that. But really, really appreciate all of your time. Matt, thank you so much. Thanks for being totally honest and sharing your experience here.
Yeah, thank you, Sonny, and thank you, Scott, and everybody who attended.
That's all the time we have for today. I want to thank Dr. Eappen and Matt for an excellent presentation, as well as Assort Health for sponsoring today's webinar. Thank you for joining us today, and we hope you have a wonderful rest of your day.